Hello, and a very good afternoon to all of the cytology community that is dialing in for this very exciting webinar this afternoon. It's just gone midday here in London on the very lucky day of Friday the 13th. And I'm sure you've got a nice movie lined up for you for tonight. But before that, we have a very exciting talk lined up for you as part of our ISC webinar series. It is my great privilege to introduce Dr. Mark Chien-Chin Chen from the Taiwan Society of Clinical Cytology. He is based at the Medical Foundation of the Chiayi Christian Hospital, and he has many major interests and areas of expertise across many fields of cytopathology and research of cancer immunology. He is on the editorial boards of many major leading journals and has himself published many articles with high impact journals and in book chapters. We all know how hardworking he is and what a joy and pleasure it is always to meet Mark in person. His infectious enthusiasm and his zest for life and cytopathology is what really makes him one of the most admired and respected people in the cytopathology universe. So, Mark, it is a great pleasure to hear from you this afternoon on a very challenging and interesting area of diagnostic cytopathology, the salivary gland cytopathology, and your experience of using liquid-based cytology in their diagnosis. Over to you, Mark.
Thank you, Ash, for your kindness, and thank you, IAC, to give me such a wonderful moment and opportunity to share my limited case experience to all of the worldwide experts. And I think today is a very wonderful day because Friday is a very very good transition period to a weekend. And I hope everyone join this webinar with your relaxed mind and open mind. And today our topic will focus on the liquid-based cytology in salivary gland tumor lesions. And I will, go on this webinar with a case-oriented discussion. And I'm Mark. I'm in Taiwan. And if everyone want to visit me, please email me. And we will always welcome your visit. And before the talk, I must disclose there is no conflict of interest, but I have a lot of interest with my friends in cytology societies. I hope everyone can join us, especially next year in Florence. So please consider to join us every ICC. And today is a Friday, so I hope everyone have a good luck, not bad luck. And go on the outlines of my talk. I will generally go through the general concept of salivary gland tumors, and then I will introduce how did we collect and prepare salivary gland tumors with our traditional preparation or liquid-based preparation. And I will show some interesting case with only liquid-based preparation, and you can guess about the pathology results. And first, I will go through all the salivary glands. Everyone knows we have three major salivary glands, from parotid gland and submandibular gland and sublingual glands. And we also have hundreds of minor glands all through the mouth roof or the other oral cavity or oral pharyngeal places. And I think everybody will know, will agree, the minor gland lesions, although they are uncommon, but they are relatively more cancerous, more aggressive than the other sites. And especially for recent meta-analysis and recent international multi-center study, you can go through about the distribution of salivary gland tumors. The most common salivary benign tumors are always mixed tumor, pleomorphic adenoma, and Warthin tumor. I think is most in almost all the countries or regions will have the similar results. And about the malignant entities, the leading proportion of cancers are still the mucoepidermoid and ADCC adenoid cystic carcinoma. And mostly they would occur in parotid gland or submandibular gland or sublingual glands. The major glands still comprise the majority. And if you go through all the lesions and with different sites or different tumor types, you will again prove our general concept. The minor gland tumors will have worse overall survival and disease-free survival and cause-specific survival. And about the ADCC from the major glands, they are overall better than the other places. The ADCC in the other places, especially in minor glands, are relatively poor prognosis. So the sites will specifically affect all the survival outcome and either the treatment strategies. In NCCN guideline, you can check the most updated NCCN guideline. FNA biopsy is still the most recommended initial diagnosis strategy. So we should do the FNA biopsy very precisely and correctly address our concerns. And they ultrasound guided or CD image guided FNA biopsy is most recommended because freehand cannot make sure the biopsy preciseness. So the image guide is still the most recommended. And about for the stage or the site, the low grade in the low stage should be treated mostly on the complete resection. Only ADCC is, although it's very low grade, but it should be treated as high grade, even they are low stage. They still need to do the radiotherapy because the ADCC frequently have the perineural invasion. So either if you don't see the perineural invasion, you should also treat it like the other high grade as with the radiotherapy. Otherwise, the low grade, if they don't have perineural invasion, you just need to observe or consider further radiotherapy if they recur. Why the several gland FNA will be very difficult? I think for being a cytopathology fellows, or if you sign out a lot of several gland lesions, you would think the several gland tumor is very difficult to sign out because the several gland has various cell origins and morphologies from the mature axonal, from the intergalactic duct, from striated ducts and exoducts. They would come from the monopopulation SCC or a very plump, very big myoepithelioma or myoepithelial carcinoma, or mixed population with the mixed tumor, basal cell adenoma or basal cell adenocarcinoma, or adenocystic carcinoma. So anyway, we have various tumor entities. In WHO Blue Book, you can check the 21 malignant epithelial tumors and 15 benign epithelial tumors, and the other 3 benign entities. So we have our FNA reporting is very, is very complex. They should comprise of so many entities. And either we also have different preparation. For the traditional preparation, I think we will do the Papnicolaou stain in the alcohol fixed slice, and we also do the dry dip quick. Or in Taiwan, we do the Liu stain is a modified dip quick or modified Ginsai method. My collection for the SGT several gland tumors are from overseas friends, our friends in Vietnam. At these 2 centers, they help me to collect their cases. We retrospectively collect 600 cases in conventional smears. And we prospectively collect over 500 cases, also in conventional smears from next year to now. And in Taiwan, I work with the National Chien-Chin University. It's a university hospital. We retrospectively collect 375 cases in conventional smears, but we also initiate a prospective collection from 2 years ago to now. We parallelly collect conventional smears, liquid-based preparation slice, and if the sample is adequate, we will do the cell block with the liquid-based tube. This is the clinical workup to show up to you. My collaborator, Professor Zhang will do the ultrasound-guided biopsy, and then he will prepare direct smears, at least 1 or 2 in dry slice and 1 or 2 in alcohol-fixed slice. And then he will do another needle pass to prepare for the liquid-based preparation in a single tube. And then this tube will send to the pathology lab to do the liquid-based slice and cell block, so that I can have a corresponding dry slice, wet slice, and liquid-based preparation. And if the sample is adequate, I also got the cell block. Let's show up, let's show up some liquid-based images for you. For the benign axini, if you do the liquid-based, you will see the axini will preserve very well, but the nuclei will be very small and hyperchromatic, darker in the staining, and the lobule-like structure will well preserved. So you can see the small lobules and axini and some lymphocytes, some degenerated macrophages or some stromas. And these are all artifacts because the needle artifacts. And we will also have some abscess lesion in the salivary gland tumors. But the abscess after liquid-based preparation would reduce their necrotic background and bloody background. So you can see mostly they are necrotic debris, and there are some contaminators and some PMN or lymphocytes. Mostly they are necrotic debris, but after liquid-based preparation, the dirty background is dramatically reduced. And if you check with the mixed tumor and Warthin tumor is the top 2 benign tumors. So I will show up the top 2 benign tumors for you. For the mixed tumor in liquid base, you will see the chondromyxoid stroma is relatively light in color, but you can still see the epithelial island, the stromal, and the connected trabecular connections. So it's a biphasic stromal component, epithelial component tumor. And if you compare to the dry leaf stain, the dry leaf stain will stain with the stroma like a dark purple stroma. And the nuclei will be much bigger than we expected. But the detailed nuclear feature cannot be seen. The nuclei is very dark in the dry stain. But for the traditional Pap stain, you will see very clear the chondromyxoid stroma. And the nuclei is relatively open chromatin. You can see more detailed nuclear features in the papiniculae staining and alcohol-fixed preparation. But for the liquid-based, the background is relatively very clear. And the stroma the stroma is relatively not so easy to be found. And you can see the epithelial cells. The epithelial cells, they are darker than the conventional slice, and they are relatively smaller than the conventional slice. And another benign tumor is Warthin tumor. Warthin tumor in liquid base, you can see they are like uncle size with a dark round nuclei. And the cytoplasm is relatively, ample and eosinophilic. And you can see the lymphoid stroma over here. If the lymphoid stroma is artifacted by the needle or by the traction, will look like this. Would be very, very tree-like or severe artifacts. So if you see such kind of artifacts, think about the lymphoid cells with artifacts. So if you see the stromal, lymphoid stromal, and the oncocytes only, you will think about the Warthin tumor. This is liquid-based. But compared to the traditional papniculate stain, conventional staining, the traditional conventional staining, you can see the nucleus is not so dark. We can still see the distinct nucleolus. And the cytoplasm, you can see more, more granular. But the lymphoid stroma still you can see the artifacts. And compared to the liquid base, you can see the liquid base is much more smaller and darker and round, not so fine, open chromatin. And if you check with the Liu stain, it's a quick stain. You can see the cytoplasm is in a purple red. And then the nucleus is very similar with this conventional pap stain. You can see somewhat a nucleolus. And this is the artifacted lymphoid stroma. Okay, if you go through the liquid base and conventional style, their differences, you would say, just like Professor Claire Michaels talk about this, I think everyone will agree the liquid base preparation is more standardized because you don't need to do the manual preparation. You just need to put all your sample into the tube, into the liquid, so that you can go on an semi-automatic or totally automatic process to prepare your slice. And their screening area is very, is very small. It's round and very fixed area. So the screening area is not large, not inconsistent. It's very, precisely sized. And you don't need to worry about the background or material will oversize your tumors because the red blood cells or the debris or the inflammatory cells are much reduced in the liquid-based preparation. I think this is also a disadvantage because someone will care about the background cells. So this is not totally a benefit. And another benefit is air dry artifacts. Because we put every sample in liquid, so the air dry artifacts would be much reduced. And because we prepare by the automatic machine and it's a thin layer preparation, so mostly they will be more monolayered, more easy to read, more easy to scan. So that if you want to do the digital cytopathology, we would prefer to use the thin layer preparation, the liquid-based preparation, because they are easy to scan. And another advantage is about they are relatively well preserved. But the well-preserved cells somehow, just as I say, if you check with the preserved cell, they are relatively smaller and darker. So someone would think if compared to the conventional smears, they are not easy to read the delicate characteristic of nuclear features. And another biggest advantage is they can do totally automatic. So if you are short in medical labors, maybe you can consider to do it, to do totally automatic. But we still need people to read. So I think it's not only, it's only reduce your workload in process, not reduce your workload in reading. And another benefits is because we put all the sample in liquid. So when we still have the liquid and we still have samples in the liquid, we can prepare another additional slice for ICC, or either we can prepare more advancedly cell blocks. I think liquid base for the ICC or for the cell blocks are very useful. So I think in recent publication, you can check more and more about using the ICC with liquid base slice. You can stain with specific markers such as salivary duct carcinoma with AR, lymphoma with CD markers, and ACC maybe with EMA or the others, NR4A staining, or basal cell adenocarcinoma with P63. So anyway, if you have liquid-based preparation samples, you can have additional slice to do the ICC stains. It will be help for the further diagnosis or differential diagnosis. But in this paper, they also discuss about the intermediate FNA cases. For the liquid-based cases, they didn't help the intermediate FNA or non-diagnostic FNA cases more. They didn't have the statistical difference compared to the conventional smears. So I think we still need more and more studies or meta-analysis to compare more their value or their differences in intermediate diagnosis and sampling and the sampling adequacy. Okay, I think I will go to the next, I think the most interesting section about the case discussion. I will show up some cases of my collection. The case one is a 42-year-old male. This is the ultrasound feature. You can see it's a unilocular cyst. It's over a left submandibular gland. It's about 4.4 centimeter. And the clinical doctor, they just aspirates about 10 cc mucinous fluid to me. And in liquid-based preparation, you can see all the mucinous backgrounds. This is much thicker. So you can see in the middle, maybe red, in the periphery, maybe in blue or green, but we didn't see any epithelial cells. We only see some inflammatory cells or some mucins or muciphages. And if you look more high power, see some muciphages or some mucus materials. Mucinous materials in liquid-based preparation, they will look like very, very thin, cotton-like distribution. And if you check the other very thin preparation area, you will see some mucophages and mucin-like substance and some lymphocytes or degenerative cells. So anyway, this is totally composed of mucin, but without epithelial cells. For a mucin and cystic lesion, without epithelial cells, can we directly put them into non-diagnostic? I think it's still very challenging because you cannot exclude the possibility of low-grade mucinous carcinoma, although it's not very prevalent compared to the other mucinous retention cyst or mucocele or the other thyroid cyst, developmental cyst. So, but if you think about, if you cannot totally exclude it, I think maybe you can put them into AUX. Because for the cystic salivary lesions, we will divide them into mucinous or non-mucinous. For the non-mucinous cystic lesion, they will be very proteinous. So if you can only check with only proteinous fluid, only histiocytes and debris, you can directly put them into non-diagnostic contents when the epithelial cell is not found. But when the epithelial component is present, a scanty, you can put them into AUS. This is for the non-mucinous. But for this case, it's a mucinous cystic lesion. So either you found the epithelial cell is good. We can check if the epithelial cells are, squamous or mucinous or goblet. But if you don't see any epithelial cells, you still need to worry about the low-grade mucoepidermoid carcinoma. So we have better to consider this possibility and classify it as AUS. So there is an algorithm for your reference. You can check it for the mucinous, non-mucinous, and for the mucinous, you can think about the mucocele or the others, or the cancerous low-grade mucoepidermoid carcinoma. But for non-mucinous, you should think about lymphoid background or non-lymphoid background. If with a lymphoid background, you should think about if they are non-neoplastic, maybe they are lymphoepithelial cyst. But if they are neoplastic lesions, you could consider about the benign Warthin tumors. For the non-lymphoid background, you can think about inflammatory cyst or metastatic carcinoma, especially for XCC. So this is for your reference. I think everyone can, check with your cystic lesions and corresponding pathology results. So for this case, I think the possibility may be, salivary duct cyst, salivary retention cyst, mucus retention cyst, and mucus duct cyst or cell cyst. But I cannot totally exclude the possibility of low-grade mucoepidermoid carcinoma, or either the oral focal mucinosis. This case is a very recent case. We still go on observe this case, and we still not to do the surgical excision. So we just follow it. So but the principle is just like this. If you have mucinous cystic lesion, just carefully interpreted it. The case two is a 48-year female. It's a cystic tumor over a right parotid gland and about 2.5 centimeters. And I think in low power, you can see this is lymphoid aggregation. And there are some debris, some cells, some debris, and some, I think, macrophage or degenerative cells in the background. And again, we can see some lymphoid aggregation here and here. And these are debris, macrophages. These are debris. Remember, it's a cystic lesion, but I didn't see some mucinous background. And the clinical also didn't say it's a mucinous cystic lesion. So I think it is a non-mucinous cystic lesion. Non-mucinous cystic lesion with lymphoid aggregation. We can think about such as Warthins, such as lymphoepithelial cyst. And again, we can see some lymphoid aggregation and some fluid contents, debris, macrophages, some debris. If we look very high power, you can see it's relative lymphoid aggregation with some macrophages. And in this field, I think I find some, epithelial cell-like lining, but I think it's just not complete. It's just detached or degenerated from the lining. So the lining cell may not columnar, may be relative cuboid. So if we check with our algorithm, I think it's non-mucinous lymphoid background, and we also find some plain-looking cuboid or low columnar epithelial cell with degeneration. So I would prefer maybe lymphoepithelial cyst. So this case may be non-neoplastic lesion. And this is the resection histology. The resection histology prove our finding because the aspiration may only take these parts. So we only have the degenerative debris and some lymphocyte macrophages and some lymphoid degeneration. And epithelial parts may not detach so much. So we didn't see a lot of epithelial cells. And if you check with our, cytology finding with the histology resection, you can check some epithelial cell, very superficial parts may be detached from the epithelial cells. And then they are just like this, with some debris, with some lymphocytes, and some lymphoid aggregation in the background. They are detached from the stroma. So this case it turned out to be a benign lymphoepithelial cyst. It's very common in pleurotic gland as a unilocular cyst and can be associated with HIV or autoimmune disease, particularly Sjogren syndrome. This is with a thin stratified squamous lining, or they also can have the ciliated or cuboid columnar epithelial lining. But the background always polymorphous lymphoid cells aggregation with possible formation of the germinal centers. So the cytomorphology characteristic is the lymphoid background, aggregation with T cell sites. And if we are lucky, we can have the lining epithelial cells and proteus backgrounds. Case 3. Case 3 is a 40-year male, a very well-defined is a very big clue for a benign behavior. In the right parotid gland, it's all around 2 centimeters. And if you see, this is a very cellular smear. And this cellular smear is mostly composed of aggregation of nodular aggregation, just like this, very blue-round cell aggregation. And if we look closer, they may look like a follicle. You can see the maybe montorone germinal center. So this is just like lymphoid follicle. And the background is also have some medium or small size lymphocyte in between. But I didn't see a lot of I didn't see any epithelial cell in this picture. And if we look very high power, you can again see the lymphoid aggregation, and Again, if you see some immunoblastic cell-like cell in the lymphoid aggregation, you will prove our suspicion for the germinal centers. So this is the highest power. You can check this lymphoid aggregation with somewhat immunoblastic, immuno-like or centroblast-like cells. So this is totally lymphoid cells. So I would think about this is a lymph node or low with reactive hyperplasia or low-grade B-cell lymphoma, because I didn't see any high-grade tumor lymphoid cell, and the arrangement of the lymphoid follicle are still, if we check in low power, are still preserved. You can see their nodular hyperplasia in a low power. So I think if you worry about the lymphoma, you should send for the flow cytometry for further, differential diagnosis for low-grade B. But flow cytometry cannot tell you about Hodgkin or the other lymphomas or high-grade lymphomas. But by morphology, I think it's low-grade lesion. So at least doing the flow cytometry can help you to differential diagnosis low-grade B-cell lymphomas. Well, this case, I eventually signed out as AUS. I signed out AUS, say it's an unusual lymphoid aggregation, and maybe it's a reactive lymphoid hyperplasia or low-grade B-cell lymphoma. Please check with the flow cytometry results, or if you are worried about the lymphoma, please do the excisional biopsy for this lesion. And this case, eventually is the lymph node. After resection, it's a lymph node. You can see the salivary glands in the parotid glands, and it's a well-defined lesions. You can see some germinal center lymphoid follicles, hyperplasia, and this is the slide. So intraparotid lymph node is very common, but you cannot make sure every lymph node are benign lymph nodes, especially by the cytology only. You cannot precisely differentiate with the low-grade B-cell lymphomas. So if you only get the biopsy, and this biopsy is very cellular with heterogeneous mixed mature lymphocytes, and the background have a lot of lymphoid aggregation and either the lymphoglandular bodies, tingible body macrophages, and a lot fragments of germinators. Although they are mostly benign, but just by cytology, we cannot confidently tell you there's no possibility for the low-grade B-cell lymphoma. So you had better to do the flow cytometry. Okay, the next case. We got 6 cases today, so we will have the next 3. Case 4 is a 39-year-old male. It's a nodular tumor over the right parotid gland. It's a 2.4 centimeters in size. So it's a nodular tumor. It's very important. It's relatively solid, not cystic. And if you check in a low power, it's relatively cellular smears. And if you check in low power, you can see they are relative distribute like a lobule-like distribution. And the background didn't have any lymphoid background or mucinous background. And in high power, you can see these islands are composed of mono population of tumor cell. They seem to just have one type of cells. This type of cells have a relative uniform low-grade nuclei, and they have pale and granular cytoplasm. If we look very, high power, you can see they are relatively uniform and low grade, similar to each other, and is a monopopulation tumor. And these tumors, they have mild to moderate low-grade nuclear TP. And if you check with their cytoplasm, the cytoplasm is relatively granular and so bubble-like vacuoles. Yes, again, if you see very clear, the nuclear change are not high grade. And the background is very clear. And we are lucky we have this case cell block. You can see there's a cell block just like axonite. These are just like a lobule of axonite get together. Some cribriform-like structures, but mostly they are aggregation of lobules or axonites. In high power, we will again to prove our concept. Yeah, they are one cell. They are not oncocytes, but they also abundant in pale cytoplasm, and the cytoplasm is relatively with small vacuoles. So this kind of tumor, I think, can be differential as actinic cell carcinoma or secretory carcinoma, or maybe someone will think about oncocytoma, or maybe someone will also think about it's a myopithelioma. But anyway, we are not, if we only have smears, we cannot put them directly into anyone. We still need to do some molecular or immunochemical staining. So we didn't put it into benign, we put it into thumb. This case, it turned out to be ACC, actinic cell carcinoma, because the staining for the STAX10 and DOC1 and CK and PAX positive for the cytoplasm. And recently, Cancer Cytopathology also provided another marker, TR4A3, for the ACC, for everybody's reference. And it's most common in parotid glands and usually very well defined. And the survival is the 5-year survival is very high. So the biggest differential diagnosis is on the secretory carcinoma. Because the secretory carcinoma has very specific gene mutation in most of the secretory carcinoma, ETV6 and TRAX3 gene fusion, and usually DOC1 negative and S100 myoglobin positive. So anyway, if you don't have a lot of material to do the further genetic analysis or immunostain, just stain with the DOC1 or STAX10 or PAS for your reference. Usually ACC is very low grade but high cellular, and they got the round nuclei with tiny nucleolus. And the cytoplasm is granular, and if you can do the PAX stain, you will be PAX positive. And if you read the ACC conventions, you would be relatively easy to see the bare nuclei in the background, but it will be much reduced in the liquid-based preparation slides. So in my liquid-based preparation slides, we didn't see a lot of bare nuclear in the background. Okay, if you compare ACC with oncocytoma, honestly, they are different. Because oncocytoma, they are relatively more low-grade. The nuclei is always round and small. The cytoplasm is much more eosinophilic, especially in liquid-based preparation, will be much more green in color. So if you see in a high power, you will understand what I mean. The cytoplasm is much more thicker and much more green to yellow in color. Although the cytoplasm is also granular. So it's for the comparison. Okay, the case 5. Case 5 is a 40-year-old male with a very well-defined tumorous margin, and is also around 2 centimeters. This case, I think, is the most difficult case of today's webinar, because only after resection, I eventually know what it is. When we receive it, you can see the low power is very cellular. But in the low power, you can see, yes, we got some lymphoid. We got some acinar-like structures. We got some acinar-like structure lymphoid. And we also got some duct-like structures, maybe in the next picture. Yes, this picture is much more easy to understood. We got some acinar-like structures, and these acinar-like structures may look like very similar with oncocytes. And we also have some duct-like structures here. And we also have some lymphocytes between the ducts and the axonal. And we also see some stromal tissues here. And this is axonal. This is axonal. And this is a stroma with some lymphocytes. And another view, you can understand what I mean. This is axonal. This is a fibrous stroma with some artifacts. And you can see some lymphoid with artifacts in the stroma. And this is duct. And this is axonal with oncocytic change. So this is the most highest power. You can see the axonal-like cells. They have a very small nucleolus. And the cytoplasm also granular, eosinophilic. So I would say, because the color is relative granular, and whether it is more green, so it's very similar with oncocytes. But this is ductal cells. Ductal cells, they are relative cuboid to low columnar in shape. Why I very confident to tell they are ductal cells? Because they are uniform in size and their orientation is preserved very well. So anyway, this is a tumor, right? 2 centimeters, well defined. But I see some axonal, I see some ducts, I see some fibrous stroma with lymphocytes. What is it? A hematoma? I don't understand, but I cannot tell it's a malignant case, right? So I had better to put it into benign currently. Yeah, because I cannot see they may have ADCC or the other features. Yeah, this case is after resection. You can see this is a parotid gland. The border is very well defined. And these lobules of axonal are all eosinophilic oncocytic changes. And they are separated by the fibrous stroma. And in the lobules, we got the ducts and lymphoid infiltrations. The duct distribution is still well preserved. Yeah, it's more high power. This is not eosinophilic change axonal. This is eosinophilic change axonal. And this is the fibrous stroma. This is stroma with lymphocytes. This case is a very rare benign entity. It's a sclerosing polycystic. It's a sclerosing polycystic adenoma. And I think you just need to remember, if you have aspiration with well-preserved axonal ducts, stroma, and with some lymphoid infiltration. And the axonal also shows some eosinophilic or oncocyte-like change. You can think of, and the border is clinically tell you it's a well-defined tumor. You can think about this entity. This entity is mostly occur in parotid gland, and the female to male is mostly slightly female predominance. Recurrence rate was 10% mostly because of incomplete resection. The morphology always preserved with the cohesive sheets of epithelial cells, and the epithelial cells have eosinophilic change. The nucleus low-grade change is relatively round to oval and evenly distribution of the chromatin with indistinct nucleolus. Why is it turned into a neoplasm? Because these kind of cases, they have consistent mutation in PI3K pathway and frequently occur in the P10, so that they would be overgrowth sometimes. Okay, the next case. The next case, a 15-year-old male, is an ill-defined infiltrative tumor. So clinically is ill-defined and also infiltrative behavior border. So it's a big hint for malignant behavior. It's around 3 centimeters. And it's in the low power is a very cellular tumor. You can see these cases have a lot of cells in the low power. If you look closer, you will very easy to find this epithelial cluster cohesive nests over here, and the nucleus is relatively ugly in some cells. And this is also relatively high grade. And we can also see some lymphoid in the background. And this is relatively higher power. You can read the tumor nest. They are relatively not well orientated. They are relatively, loss of orientation, and NC ratio is very high. And this is, again, relatively high power, high grade, sorry. And this is relatively low grade here. But again, this is a cellular and high grade tumor. And you can check with this. Somehow they also have glandular structures and with some lymphocytes. But in this case, I didn't see some necrotic debris. And because this is a cellular case and the epithelial cells are very high grade, so I will put this case into malignant case. And after resection, you can see this is the border. The border is relatively infiltrative, not so well defined. And the tumor nests have some apoptosis, necrosis, and some quiviform structures. And the nuclear change is relatively very high grade. This case is turned out to be a salivary duct carcinoma. Salivary duct carcinoma is one of the most prevalent high-grade salivary gland cancer in salivary gland neoplasms, about 10% of malignant cases. And the patient's mean age is relatively older than the others. Then male to female is male predominance. Most commonly affects on the parotid gland. And these kind of high-grade tumors are usually very cellular. And we were easy to find that epithelial cell with ugly and high-grade polymorphic nuclei. with frequent mitosis and apoptosis. And AR will help you to do the differential diagnosis for the other metastatic carcinoma, because they are very high grade. So your biggest differential diagnosis is the metastatic carcinoma from the other places. And the molecular alteration may involve FLAG1, MGA1, and the others. He didn't have a very specific molecular marker. So again, I end my webinar here, but I think everyone have your interesting case. Maybe in the following webinar, I would look forward more and more people to share your interesting case and share your happy hour with us. And I hope everyone can join next May's ICC in Florence. And now the submission is beginning. And I hope everyone can registration and then can have your registration and submit your interesting cases with oral presentation or posters.
Mark,
and thank you and see you soon. Yeah.
Thank you, Mark.